Those of you that have taken the boards that didn't score what you wanted to, you know how basic of a level they ask on the micro questions. They'll turn around, they'll give you a vignette of something, and in the vignette they'll tell you gram-positives, and other students even told me the same thing. You look down, there's only one gram-positive on the list, folks. It's that basic, okay? So if you start digging into the details, wanting to know all the layers of whether it's gram-positive, gram-negative, things like that, that's a lot of extraneous stuff, and maybe one question on that, but there's going to be 15 on identifying the bugs, okay? So you want to go with where the bulk is. As far as micro is concerned, it's all clues. Here's a bug, here's a clue, here's the drug maybe. And let me explain what I mean maybe. If they ask about a certain drug on a certain bug, I'm going to give it to you. If they do not, or I do not have it on the slide, it's because they constantly ask about that organism as a diagnosis question. Okay? As far as pharmacology is concerned, a little later we'll actually hit the farm. I'll sum up the farm a little later. Normally I do it in the beginning, but I think it's going to be better to do it later. And the farm, how I approach micro-farm, is I approach it via classes. I do not approach it via, do I use naphicillin? Do I use oxacillin? Do I use cephalosporin? Do I use ceftriaxone? Whatever. Not going to do that. Because if you guys open your first aid, you know they'll give you a bug, and they'll give you 4 or 5 drugs. One's a penicillin, one's a cephalosporin, one's a macrolide. And you're like, crap, how the hell am I going to remember all this? This is just rogue memorization. Cephalosporin, macrolide. And you start running through this memorization process in your head, and 2 weeks later, all of a sudden, it came out your porthole, and you don't even remember the material anymore. So, if you stop and look at it from a class point of view, you know that ultimately you can get the answer. Let me explain. When you guys do farm questions, I know I mentioned this to you before, and they ask you for a drug and you look at the list, you can always go, oh, that's a cephalosporin, oh, that's an imipenem, you can put it into a class, but then you forget what the mechanism of action is of that class because you're studying individual drugs. Don't do that. Study classes. So later on, we'll address the big class of the drugs. All right, so find a blank piece of paper in your notes, and I'm just going to give you some information. When we talk about normal flora, you got to remember that normal flora is there to protect you, really. Normal flora is there to protect you. Now, if I get any invaders in my body, normal flora should clear that up. However, normal floras can get out of control too every time I have immunosuppression. You know that your gut GI flora could get out of control if I have hypomobility, which we discussed a little earlier. I know that if I change the pH in a female patient, she can have her normal flora get altered within the vaginal cavity. So normal flora is there to protect you, but it can also harm you in points of immunosuppression. Based off of that, remember, also normal flora changes with age. The flora a child has or an infant has is not the same flora that we have as we get older. Why? Because we're constantly insulting our bodies due to environmental insults, toxins, steroids, everything that we take in. So our GI flora basically changes with time because of the exposures that we have or are exposed to. I mean, a lot of you guys don't know this today, but I mean, like when I was back in high school, most high school seniors playing football, the average between 150 to 170. That was the average size. Look at a high school senior now, 220, 230. Outside of the anabolic steroids they've been sticking in their ass, ultimately, most kids nowadays are much, much bigger. Much bigger. Why? How about the food that they consume from McDonald's, that 5-star restaurant? All the meat that they're consuming. All these farms that are doing genetic testing to make the crops bigger and pumping those animals full of steroids. So every time you eat the foods nowadays, that's what's happening. So the general population is not only getting fatter, but they're getting larger, meaning mass size. And the problem with that is these are going to be the patients that you're going to deal with when they get older. They're going to have all types of bone problems because of carrying that extra weight around, as well as things with the adrenal glands getting screwed up from the steroids they're taking from diets and things like that, or from normal nutrition. So the food that we have nowadays is very dangerous. That's why there's this push to go organic. You know, I don't think it's ever really going to take off too much other than a small population that likes that. Now, remember that ultimately, if somebody's immunosuppressed, I said the normal flora is going to take over. But what part of your normal flora takes over in immunosuppression? Yeast. Yeast always takes over first. So how do I know that? If somebody's immunosuppressed, don't they get candidiasis? So yeast always takes over first in immunosuppression. Always blame it on yeast. Now, if I'm looking at the normal flora and I'm looking at the skin, what's the most common organism on the skin? Nope, not that. Most common organism on the skin is staph what? Epidermidis. Good. Staph epidermidis. Staph epidermidis. What about in the nose? Organism is? Aureus, absolutely. Oropharyngeal or oropharynx is what? What do you think? Strep, which one? Good, viridans. You exercising, Cammie? All right. Yeah, well, it's going to take more than one day. All right. Gingival? Anaerobes? Most commonly, actinomyces. Shoot. Actinomyces, and again, Fusiobacterium. And last but not least, in the vaginal volt, lactobacilli. Also, remember, you can have group B strep. So normal flora is there to protect you. If I have an immunosuppressed individual, I'm always going to blame it on yeast first. Yeast of the normal flora will get out of control. If it is cutaneous, staph epidermidis, most common. Nose, staph aureus, so nosocomial infections. Oral pharynx, I'm going to always blame it on strep viridans. Gingival, I'm going to blame it on anaerobes, which hate oxygen, so actinomyces and Fusiobacterium. And in the vaginal volt, I'll always consider lactobacilli or group B strep. Now, when it comes to the organisms themselves, I'm going to give you a pattern for the boards. A pattern. So if they tell you on staining, staining clues, and they tell me it's gram-positive cocci, gram-positive cocci, it's always going to be staph or strep. Staph or strep. If they tell me it's gram-negative cocci, I always want you to choose either Neisseria or Moraxella. Now we're going to go through all these. I'm just giving you a platform. Gram-positive rods, otherwise known as, Bacillus, Clostridium, Listeria, and Corneobacterium. If they tell me gram-positive branching rods, I'm going to always consider nocardia and actinomyces. If you get a question where it's basically none of these, meaning gram-negative rods, or say gram-negatives, could be rods, could be spiral, comma-shaped, doesn't matter. All else is gram-negative. So if it's gram-positive cocci, I want you to choose staph or strep. Gram-negative cocci, I want you to choose Neisseria marxella. Gram-positive rods, consider bacillus, Clostridium, Listeria, or Corneobacterium. If it's gram-positive branching rods, consider nocardia or actinomyces. And all else would be gram-negative rods. And remember, that could be spirals, commas, rods, anything they give at you. So again, this is kind of a template. When you see these staining patterns, these are the organisms that they're most commonly test on. Okay. If they turn around, and there's two terms that they love to do. They love to do something called exotoxins and endotoxins. Endotoxin. So endotoxin are gram-negative. Exotoxin are either gram-positive or gram-negative. So I know that under endotoxin, there's lipopolysaccharide. Lipopolysaccharide. And the toxic portion is lipid A. Lipid A is the toxic portion. Endotoxins also increase the number of macrophages. So therefore, you would increase the number of cytokines. And if I increase the number of cytokines, ultimately it leads to all kinds of problems. So again, endotoxin, gram-negative, lipopolysaccharide, toxic portion is lipid A, increases the number of macrophages and therefore also increases the number of cytotoxins. For exotoxin, it has what we call an A-B component. A-B component. A is the toxin, or the active toxin, and B is for binding. When somebody has an exotoxin, they're also at risk for exfoliation, meaning Nikolsky sign. Remember, that's if I take my hand and I rub it over the patient's skin, it'll start to slough off. That's Nikolsky sign. You're exfoliating exotoxin. Kind of sounds like the same thing. All right, so exotoxin, again, I'm just giving you some little bit of pointers of if they decide to go for this. Now, virulence, let's talk about that. Virulence. They must colonize the host, so virulence. Virulence. Well, if I'm talking about a gram-negative, gram-negatives use pili or fimbriae. So an example would be like gonorrhea. Gram-positives use teichoic acid. Teichoic acid. Now let me give you an example here. So let's say somebody has an infection with gram-negative, I don't know, let's say gonorrhea, and you know it has all these pili. Well, think about it. Urinary tract infection, well, not a urinary tract infection, but it's within the urethra and all that. Neisseria gets where it needs to via the pili. It crawls, right? But I need some type of virulence factor where it's hanging on using the pili so when urine goes by, it doesn't flush. So that's what allows Neisseria to hang around longer. Also, the pili are what transform over every couple years, and that's why we get resistance to Neisseria. Okay, so it's the pili that are doing the transformation. We have IgA protease. Is a virulence factor. Because remember, it is a monomer or dimer, Bartholin, IgA in the mucosal. It is a dimer. So if I have IgA protease, ultimately it will allow this organism to hang around longer in the oral flora. There are capsules that are virulence. Who has the largest capsule? Anthony? No. Nope. Keep rolling. Who has the largest capsule? Anybody? Neisseria. 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 Now, why is it that a capsule leads to virulence? What is unique about a capsule that leads to virulence? How does a capsule cause virulence? January? Sure you do. It's a shell, right? You ever try eating a walnut? Can you eat through that walnut? You'll be chewing for a while, won't you? Watching your teeth fall out and all that, right? So maybe every time you go to try to bite a walnut, maybe it rolls. So let's say you put it on the table and you try and bite it, and it keeps rolling and rolling and rolling. That's why capsules have a virulence factor, because you can't grab onto them because of that capsule. And let's see, antiphagocytic surfaces. So let's see. Antiphagocytic surface. And this would be like, I don't know, strep pyogenes. Get it right. Strep pyogenes has something called an M protein. So it cannot be phagocytosed. Neisseria, gonorrhea, has the pili. And Staph aureus has protein A. So again, virulence, we have gram-negative pili fimbriae, gram-positive teichoic acid. There's IgA protease, which allows things to hang around in the oral mucosa. There are capsules, largest one in Neisseria, with Neisseria. Remember, it's hard to grab them, so they hang around longer. And antiphagocytic surfaces, such as strep pyogenes, has an M protein. Neisseria has pili, and Staph aureus ultimately has protein A. All right. Now, when we talk about neurotoxins, so basically, folks, what I'm doing here is giving you a cheat sheet of the most commons. Neurotoxin. When we're dealing with neurotoxins, we always deal with Clostridium. And there's Clostridium tetani and Clostridium botulinum. Clostridium tetani and Clostridium botulinum. Well, when I have Clostridium tetani, what do they describe that as? Is it painful or painless? Painful contractions. Painful. It's a spasm. A spastic spasm. But with botulism, don't they say it's a flaccid paralysis? So the same organism, Clostridium, but different subspecies, tetani versus botulism, ultimately have two opposite ends of the spectrum. One contracts, causes spastic paralysis. The other one is flaccid paralysis, relaxing. Okay? Those are the two neurotoxins that they love to go for on the boards. Let's see. Evading killing. to evade killing. There's two organisms that love to evade killing that are very hard to kill. Mycoplasma, tuberculosis, so evade killing. So evading killing. Mycoplasma tuberculosis and listeria. Yes. I'm sorry? Mycobacterium tuberculosis. Yeah, mycoplasma. I'm sorry. Yeah. Mycobacterium tuberculosis. Sorry, I misspoke. So Mycobacterium tuberculosis. Mycobacterium. Thank you. Mycobacterium tuberculosis and listeria. So what is it about Mycobacterium tuberculosis? Mycobacterium tuberculosis has a cord factor. Has that cord factor, so ultimately the macrophage comes down and engulfs it, but can't chew it up. It cannot chew it up because of this cord factor, so who does it call for help? T cells, folks. T cells surround it, and ultimately you get your granuloma. Gone focused, gone complex. That's what that is. So due to cord factor, Mycobacterium tuberculosis cannot be killed. Listeria, it jumps from cell to cell. Let me explain. So if I have a cell here, and I have my phagosome here, and my phagosome takes up the listeria, and then I have lysozymes, and I have lysozymes, or zomes, whatever. Their function is to ultimately take that phagocytic area and chew it up. But what actually happens is on their way to this, listeria jumps out and goes to another cell. So it hops from cell to cell. So when it hops from cell to cell, it can keep replicating. So that's why listeria is so tough to kill. Your normal immune system has a very, very hard time killing listeria because every time it attempts to, it just keeps hopping on to the next cell. It's the problem with listeria. And last but not least, we're going to talk about types of augurs there are, and that's a dead giveaway too. So when we talk about media, we talk about McConkey's augur, ferments lactose, If I talk about EMB, that's eosin, methylene, blue, and that's for fecal stool. So therefore, E. coli. Buffer charcoal yeast auger. Or extract auger. For Legionella. They talk about chocolate auger. I'm going to think of Neisseria. Or Haemophilus. Now you know that they sometimes with chocolate auger, they talk about an X factor, which is heme. And they sometimes talk about a V factor, which is NAD. Bottom line is, what the hell does that mean? Folks, what they love to do on the boards is they'll give you a drawing of a Petri dish. And if they give you any drawing of a Petri dish, and on the dish you see a disc and another disc, and there's a line between the two, that's chocolate auger. That's the X and V factor within those two. That's all it is. You got your answer right there. So it's either Neisseria or Haemophilus. Drop down, pick, get the heck out of there. And last but not least, and basically with chocolate chocolate agar. It's just red blood cells lysed, folks. Red blood cells lysed. And TCBS, don't ask me what it stands for because I'll never put it on there, is for Vibrio. Vibrio cholera. And it ferments sucrose. And it turns orange is the clue. It turns orange. So Vibrio cholera on TCBS ferments Vibrio cholera, grows Vibrio cholera, ferments sucrose, and it turns orange. Okay? Those are the high-yield facts that I want to make sure you have that they commonly test on, just at the depth that I presented it to you, folks. Not any deeper than that. Orange. Remember, pathologists as well as microbiologists love food. All right. Normal flora. Let me explain to you what we're going to do here with normal flora. Normal flora is basically where I'm going to say, these are the bugs I find in that area. When we get into gram-positives, gram-negatives, rickettsia, and so forth like that, we're going to break those down even further. Okay? So I'm just showing you, or basically orienting you versus normal flora. What would I find in certain parts of the body? What organisms are more prone to those parts of the body? That's all normal flora chapter is right now. All right. So if a bacteria normally lives on a part of your body exposed to oxygen, no surprise, you're going to call it a gram-negative. Gram-positive. Woo. All right. Gram-positive. All right. Gram-positive. Look at the slide, idiot. All right, gram-positive. Now, if I turn around and have a situation where if the bacteria does not live on your body, normally exposed to oxygen, I always want you to consider a gram-negative. Gram-negative. If I'm turning around and I have a situation where there's something that kind of likes both, likes the oxygen, likes the lack of oxygen, we call that facultative, right? That means that it kind of likes both, can't make up its mind. Something that likes both is called facultative. Facultative, okay? All right, so facultative means loves both. All right, so skin flora. Well, we have Streptococcus, or I should say Staphylococcus aureus, and with Staph aureus, on your notes, I believe the second one down says Strep pyogenes. Change that to Staph pyogenes, okay? That's an error in the notes. Staph pyogenes, because Staph pyogenes is the old name for Staph aureus. So if you see that on the test and you're looking for Staph aureus and it's not there, but Staph pyogenes is, they're just using the old nomenclature, okay? So Staph pyogenes is the same thing as Staph aureus. Remember, it's notorious. Staph, you get cellulitis, omphalitis, mastitis, so just basically skin infections, things like that. If a woman has mastitis, Al, do we still have her breastfeed? Yeah. All right, good, absolutely. Staph epidermidis, remember those are something that are deep to the skin. Deep to the skin. So Tatiana, what would be deep to the skin? I'm sorry. No, what could I put in a person that would be deep to the skin? That this organism, epidermidis, loves? Now, IV superficial, right? So how about go a little deeper than that? Central line, okay, is deep. And a VP shunt, because I'm going under the skin. I'm very deep to that. Okay, so VP shunt or central line. Staph saprophyticus can lead to urinary tract infections. And Propionibacterium acne, again, is a gram-positive anaerobe. And that's what's in our glands that sometimes causes acne. Right? This kind of says it within the name. Now, Strep pyogenes is number one. Only number one. I want you to always pick staph on the skin for all infections. But Strep pyogenes is only number one in these 5. So if they're talking about lymphangitis, How do I know somebody has lymphangitis? They'll describe it as a person has an infection, and there's a red line going up their arm. A red line going up their arm, and ultimately I know that's lymphangitis. Impetigo, remember that's the honey-crusted lesions? That's a pathognomonic, we always know that. Strep pyogenes for that. Necrotizing fasciitis, that's flesh-eating strep. Compartment syndrome, necrotizing fasciitis. You guys, anybody ever been, hopefully not exposed to this, anybody ever seen this? Necrotizing fasciitis? How do we treat that? Cut the limb off? Yeah, well, that's definitive, okay. Cut around the margins? Well, we go ahead and we try debridement, and then we send them to hyperbarics, right? And then you always see that. You'll see these wounds open, packed with gauze, and you send them to hyperbarics. Let me tell you about hyperbarics quick, real folks, because sometimes you'll read in literature about hyperbarics. Hyperbarics is overrated. I can say that because I spent 6 years in the Navy as a diver, and all I did was hyperbarics and travel all around the world. I, unfortunately, had a real bad accident one time and was thrown in a chamber. I was there for a week. I didn't think I was going to make it. I had the bends, I had everything. It was really bad. Hyperbarics, obviously designed by the Navy, is ultimately there to prevent basically the bends from divers. And this is what happens, folks, when it comes to the bends. If you take a balloon and you blow it up, and you turn around and you dive in a pool and you start going down, what happens to that balloon? It gets smaller, right? Because I'm changing the pressure. But now, flip it around. You hold your breath, go down underwater, you blow into that balloon, and you start to go up. What happens to that balloon? It gets larger. You got to remember when you dive, depending on whether you're mixing tanks or whatever, normally you breathe about 79% nitrogen. 79% nitrogen. Very, very small molecule. So when you're breathing that in at a lower depth and you start to come up, what's going to happen to those nitrogen bubbles? They're going to get bigger. And when they start to get bigger and you get to the capillary beds, it's going to hurt. It's going to feel like what they describe it as. Well, I've never had a sickle cell crisis, but that's what they described it at. It was excruciating pain in all my joints. I couldn't move. I was frozen. I was actually frozen even before I broke the surface. And they had to take me up and put me in a chamber. And they kept me in the chamber, and they drop you back down to 8 atmospheres, and then they slowly bring you up. Problem is when you turn around and have those air bubbles at the capillary beds, are you getting any blood flow to those areas? No. So you can destroy joints, destroy everything in that area. And that's the danger to it. So you got to move really quick with these patients. Well, the medical community said, whoa, hey, wait a second. If I turn around and I give high flow oxygen to somebody, ultimately this must be a good thing. So let's make what we call these monochambers, which is what you see in the hospitals, and we'll slide somebody in there. And ultimately, let's say a firefighter comes in and has carbon monoxide poisoning. I'll do what's called an off gas, where I'll give them a bunch of air and try and push that oxygen off, or the carbon monoxide off via oxygen. So competitive inhibition is really what it comes down to. That works for that. But when it turns around and works on tissue, the reason you see these individuals with their skin still open and the gauze packed in is because it only penetrates 1 to 2 millimeters. So it really doesn't go anywhere. So if I suture that wound back up, I'll never expose the risk of that organism to that area. So monochambers are very, very overrated. If you turn around and go to a facility and they're jumping up and down going, woo, we have hyperbarics here. So what? As far as the medical community, it's very overrated. For diving, fantastic, saves a lot of lives. Very, very important. Yes? Okay, so great question. How is diving with the tank different than what we call bounce diving, which is diving from the surface holding my breath, right? Let me ask you this. If I turn around and bounce dive, meaning I take that balloon and I blow it up on the surface and I dive down, what happens to that balloon again? It gets smaller. But what happens when I go back up to the surface? But it goes back to its original shape. So do you see how holding my breath, diving down and coming back up, like the pearl divers who hold their breath and go down? That's okay. They won't get Caisson's disease or the bends. But if they're down there sucking on a reed, trying to get air through that, which some of them do to stay down there longer, you see how I'm breathing air down there? And ultimately when I come up, they can get the bends. So again, if you bounce dive, you don't get the bends. If you breathe air underwater, you get the bends. You can get the bends. Risk of it. All right. Enough of that in my personal life. So erysipelas, is, let's see, raised edges. And this is the one where when we talk about like cellulitis versus erysipelas, is it does not blanch. What does that mean? If I turn around and take my thumb and I start pushing on this area, I should see it blanching, see it kind of spread out. This does not. No blanching for strep pyogenes. No blanching. And scarlet fever, that's the sandpaper rash, strawberry tongue, and one of your palms and soles. Folks, out of all the PP clues you have to learn, that is the most important, palms and soles. I guarantee you will have no less than 4 questions on your boards where they will put palms and soles in the vignette. No less than 4. That is your strongest PP clue that you could ever learn. All right, so skin infections. What do we see on the skin? I had to shift some pictures. You have the pictures in your notes. But with skin infections, cellulitis. Cellulitis is, remember, flat red, but it blanches. Blanches. Cellulitis blanches. Strep pyogenes does not. If I'm looking at mastitis, that's cellulitis around that breast. And as Al told us, we always have that mom breastfeed continuously. You got to clear that duct. Have to clear that duct. If I'm looking at Blantis, Blantis is an infection of the head of the penis. Head of the penis. Blantis. If I'm looking at paniculitis, remember that cellulitis around that abdomen? Right around the center, mid-gut region, that's a paniculitis. So if you see that term in the vignette, you know what it is. Orbital or periorbital cellulitis in infants, it's usually due to some type of trauma, and it'll be a little kid with a swollen eye. Little kid with a swollen eye, and Staph aureus here. If I'm talking about orbital cellulitis, that's where they get that ptosis. Older patient, and folks, it looks like their eye is really angry coming out. Strep pneumo is associated. And a carbuncle, nodular induration with infection. So again, this is just basically a carbuncle is just in a little infected area, okay? Just a little infected area. Versus a furuncle, that's a hair follicle in the middle of that carbuncle, but there's no pus. So if they tell you in the vignette that a hair follicle is affected, there is no pus, do not pick carbuncle. It's furuncle. Okay? Do not pick carbuncle. It is furuncle. Carbunculosis is a deep skin infection where it basically is the same thing as a carbuncle, but there's a whole bunch of them all around in a certain area, draining all kinds of pus in that area. Okay? So a large area is affected. Staph aureus notorious. And furunculosis, again, is just mini hair shafts. Where would I see this on an individual on the nape of their neck? Lots of hair, so if they have acne on the back of their neck, where there's a lot of hair follicles, somebody who has a hairy chest, lots of infections on their chest, a woman who has hairy legs, ultimately furunculosis, okay? So furunculosis. And skin infections, fasciculitis, it's inflammatory of the fascia, and the 2 types, I can have plantar fasciitis or necrotizing fasciitis. We just talked about necrotizing fasciitis, and for plantar fasciitis, remember that's a lot of times due to a heel spur. Remember, that's osteophytes basically trying to fix that bone from some type of trauma, and ultimately they can get plantar fasciitis from that. Folliculitis is an infection of the hair shaft. So remember, follicle, hair shaft, folliculitis. Belpharitis is an infection of the eyelid. So you see somebody with a huge infection on their eyelid. They give you a photograph of that on the test. It's belpharitis, folks. Belpharitis. Those are the big ones that they constantly test on, folks. Okay? Those are the real big ones. Now, shoot. Carbuncle is where there is no hair in the shaft itself. It's just, remember that it has pus. Folliculitis has no pus, okay? No pus.
Folliculitis has no pus?
No pus in the hair shaft. Carbuncle has pus.
Furuncle has no pus.
That's what I just said.
Okay, I missed it.
All right. Yes? I'm sorry? Sure. Cellulitis blanches. Cellulitis blanches when you push on it. So when you push on it, it kind of spreads out. That's the big one for cellulitis. So in the vignette, if they tell you it blanches, I want you to pick cellulitis. Now, in the mouth flora. Now remember, folks, I'm just telling you what's in these different areas. We're going to go through all of these individually. We're going to break them down. So I'm just kind of giving you a run towards what's in certain areas of the body. So in the mouth, I have strep pyogenes. Strep pyogenes, and I know that strep pyogenes itself, group A, beta hemolytic strep, rheumatic fever, strep pyogenes. Yeah, we have these Jones criteria. Is the heart affected? Is the joints affected? And if it's the joints, it's poly, meaning multiple joints. These are all major criterias. They'll talk about Sydenham's chorea, which is a movement disorders. That's part of Jones criteria. Erythema marginatum, or migrans, marginatum it is, for the skin infections. That's pretty much it for strep pyogenes. Strep pneumonia, H. influenza, and Neisseria, all three of those have IgA protease. Strep pneumonia, H. influenza, and Neisseria catarrhalis all have IgA protease. So therefore, they're hang around in the oral flora. So if I ask you the most common cause of sinusitis, it's in the exact same order. Strep pneumonia, H. influenza, Neisseria. Okay? Same order. Now, if I'm looking at Peptococcus plus Peptostreptococcus, folks, I put them on there because that's what we find in the oral flora. Very, very low yield for the boards. That's something that they really don't ask about. But they do ask about Fusiobacterium. And how do they ask about Fusiobacterium? Remember, you can get Vincent's angina. Remember, that's painful ulcers at the back of the throat. Painful ulcers at the back of the throat. You also, from Fusiobacterium, is notorious for trench mouth. Trench mouth. And that would be pus coming from the gums, would be the clue in the vignette. Pus coming from the gums. Now, Actinomyces israel, they will talk about draining fistulas. They will also throw in the vignette, I've never seen it skipped out of a vignette, sulfur granules. Sulfur granules or draining fistula. So if they turn around and they describe, and they get real unique about how they describe the draining fistula, if they turn around and say somebody has an infection and it is leaking to the surface of the skin, folks, that's a draining fistula. They describe it instead of saying draining fistula a lot of times. Strep viridans, we have mutans, sanguinis, and salivarius. The only one of those three that they love to ask about is mutans. Mutans. That's in your dental carriers. Remember, it ferments glucose. Ferments glucose. That's your dental caries. Remember that strep viridans is responsible for subacute bacterial endocarditis. Subacute bacterial endocarditis. Okay? In the stomach, we have H. pylori. Oh, Lord, we beat this little dude to death, right? If I turn around and I take a sample, what is the test to diagnose H. pylori? What is the test again? It turns green? CLO. CLO, Campylobacter-like test, right? Campylobacter-like test. Do I use a urease breath test to diagnose? No. I use it to follow treatment. Follow treatment. H. pylori is the most common cause of gastric and duodenal ulcers. Urease-positive bugs, remember that urease-positive bugs are notorious for causing UTIs. And remember your P punches. This is your second most important PP clue that you could have on your list. Lots of questions are answered off the urease-positive bugs. Third most common, I would say, is curved rods, because they always throw that in a vignette, curved rods. If I see curved rods, I don't have to read anymore. I drop down and see how many of those are on the list. Is it Vibrio, is it Campylor, is it Listeria, or H. pylori? They will never have more than 2. And if they do, they'll have something really specific, because either they're talking about gastric ulcers, they're either talking about somebody who's got watery diarrhea. They'll make it real specific if they have 2 of them on there, but most of the time they have 1 and only 1. And if I know the PB clue is these 4 follow curved rods, I'm going to click and move and get out of there. Small intestines. 95% of E. coli. You know that I need E. coli down there. How else am I going to process vitamin K? E. coli helps process vitamin K, so ultimately the liver can make factors 2, 7, 9, and 10. Because if I turn around and I knock out my E. coli, meaning I put a patient on antibiotics for an extended period of time, let's say greater than 7 days, they can knock out their normal flora. E. coli, therefore, have a problem clotting because factors 2, 7, 9, and 10 are no longer working. Okay? So it's important to have that E. coli there. Small intestinal infections. Small intestinal infections. So we have cholecystitis. We have ascending cholangitis, appendicitis, or basically appendicitis, spontaneous bacterial peritonitis, and abdominal abscess. The point is no matter how many I throw on this list, whether it's cholecystitis, ascending cholangitis, all small intestinal infections. Now, if I turn around and I tell you that there is an intestinal abscess, if there is a perforation, who are we going to blame it on? If somebody has a perforation, who do we blame it on? Aerobes or anaerobes? Anaerobes. If there's a perforation, anaerobes. How do you treat it? Make exposure to the skin. Put a draining track in there and expose it to the skin. Because then oxygen gets in there and it's going to kill that anaerobe. So again, if I have a perforation, that's one of the things I'm worried about. Now, E. coli makes up 90% of your vitamin K. We talked about biotin being a cofactor. And folate. Folate also responsible. Folate's required for rapidly dividing cells for purine pyrimidine synthesis. And therefore, all pregnant women or all women to be pregnant who are sexually active should be on folic acid. How long prior to attempted conception? 1 month at least. 90 days ideally, but at least 1 month. At least 1 month. Because remember, that fetus is a rapidly dividing cell. And last but not least, pantothenic acid. Remember, that's a cofactor there. Now, E. coli helps you absorb vitamin B12. And if somebody has a vitamin B12 deficiency, how can I find out? What test do I run? Schilling's test. Schilling's test. And if I have to run a Schilling's test because there's 3 possibilities, well, I don't know, maybe it's a diet problem, maybe it's a GI problem, meaning pernicious anemia, not produce an intrinsic factor, or last but not least, they cannot absorb it in the distal ileum, because remember, that's where B12 and intrinsic factor ultimately get reabsorbed. So how do I find out about the 3? I do the Schilling test. I get vitamin B12 radio-labeled. But let me back up and say one comment first before that. Before we give that, we give B12 IM first. Okay, the reason is because there's a lot of processes in our body that use B12, like methylmalonyl-CoA and things like that. So I'm trying to saturate those or keep them busy with the IM injection of B12 while I'm testing the GI tract with the oral B12. So it's a little more than you need to know, but I want you to understand the big picture. So now I give vitamin B12 oral, and it's radio-labeled, and if I turn around and see that radio-labeled marker in the urine, I know that the B12 was absorbed. It is a dietary deficiency. Dietary deficiency. However, if I have a situation where I do not see that radio-labeled B12 in the urine, then I'm going to give radio-labeled intrinsic factor along with B12. If I find it in the urine, then I know that they were deficient in intrinsic factor, rule them out for pernicious anemia. And last but not least, if I turn around and I give B12 and intrinsic factor radio-labeled and it does not show up in the urine, I know it is the lower GI tract that's affected. Rule them out for Crohn's, ulcerative colitis, whatever the situation is. Okay? That's your Schilling's test. Now, distal ileum and colonic flora, we have Proteus. We have Klebsiella, which is real common down there. Serratia marcescens, Actinobacter, Citrobacter, and E. coli. So now for Proteus, it's the second line in UTIs. Klebsiella, third line in UTIs. And how do they describe Klebsiella? Remember, that's that current jelly sputum. Current jelly sputum. And all that is blood mixed in with the mucus, folks. Serratia marcescens, it also can cause GI infection as well as UTIs. Actinobacter, how do they go after that on the boards? If they give you any newborn, an infant with meningitis who has cerebral abscesses in a newborn infant, it is Actinobacter. Okay, multiple cerebral abscesses. And that's, remember, in infants up to, basically, it's up to 2 months of age within that window. Ooh, I'm sorry, I said that wrong. Yeah, you're right. I'm sorry. Take everything you just said and put an arrow next to Citrobacter. I was just seeing if you guys were awake. Thank you, Daniel. Actinobacter is who I would find in an immunosuppressed individual on a ventilator in a hospital. Ventilator patient in a hospital. Thank you. And E. coli, small intestines. Small intestines. You know that ultimately I just told you need it for the clotting factors 2, 7, 9, and 10. All right. And your big mama anaerobes. Big mama anaerobes. What are they going to ask you about that? Bacteroides fragialis. It's an obligate anaerobe of the GI. Obligate anaerobe of the GI. Strep bovis, and Clostridium melanogosepticus. Both of those are at risk of causing colon cancer. So only have one on the list. So if they ask you for a bacteria associated with colon cancer, it's either Strep bovis or Clostridium melanogosepticus. And Clostridium difficile, pseudomembrane colitis. Remember, that's from somebody who has been on antibiotics for an extended period of time, C. diff. Okay? Clostridium difficile. These are your big mama anaerobes. And in your rectal flora, you know that ultimately you have group B strep, E. coli, and Listeria. Remember baby bell for meningitis, BEL, because group B strep would be the first. E. coli followed by Listeria. Remember, Listeria affects the really young and the really old. Affects the really young and the really old. Yes? Big mama anaerobes. Just a nickname. Big mama anaerobes. They're the big boys. They're the big boys. All right. So basically, get ready for the ride, because from here on out, it's just clues, clues, clues. All right, so Staphylococcus gram-positive cocci in clusters. In clusters. Gram-positive cocci in clusters. So, I hate charts. I can't stand charts because charts are rogue memorization. But for you pebble flippers, I created one so you can reference this chart. And we'll go through it. So for Staphylococcus, I'm thinking about Aureus epidermidis and Saprophyticus. So with Aureus, they talk about gold pigment, epidermidis, white pigment, and Saprophyticus, there's none. But I know with Aureus, there's beta-lactamase. So what are they going to ask you about that? Well, if I'm giving penicillin and it has beta-lactamase, and they want to know what part of penicillin is getting affected, always remember that penicillin looks like a house and a garage. And is always, always, always the garage door that's affected. So what they'll do is they'll give you like A, B, C, D, E, F. That's what they'll give you. And it's always a garage door that's being affected. So they'll give you that drawing, and you just got to pick that. But recently on the boards, they tried to get a little sneaky. They put a cephalosporin on there. And this is the drawing for cephalosporin. Ooh. Tough one, huh? Folks, it's still the damn garage door. All right, so they figure they just try and rally you a little bit. So penicillin, cephalosporin, it's a garage door that's always ultimately being affected. All right. Coagulase positive ferments mannitol on salt agar. Remember, it's the number one cause of osteomyelitis. Number one cause of osteomyelitis. Versus staph epidermidis. Remember, that's the deep to the skin, so VP shunts, central lines. Coagulase negative, and these are prostatic devices, is who would be prone to that. Maybe I told you, maybe I didn't, about Arnold Schwarzenegger. Did I tell you about him? All right. Well, you know that he had to have a valve replacement, right? His aortic valve was replaced? Think about this for a second. Good old Arnold Schwarzenegger, in all his infinite wisdom, with all his steroid use and all that, what happened to his heart? It enlarged. And when his heart starts to enlarge based off of just the weightlifting and things like that, the annulus got bigger. And when the annulus of the heart got bigger, the valves can just go blow by each other. They no longer connect. So he had aortic regurgitation, and he had to have an aortic valve replacement. Well, you have two options. You can go with a prostatic valve, or you can go with a pig valve. Prostatic valve gets replaced about every 20 years, and pig valve has to get replaced earlier than that. So he decided he didn't want to have operations or multiple operations and went with the prostatic valve. The downside about getting a prostatic valve is you got to be on warfarin the rest of your life. So because he's on warfarin, he stopped making movies because he can't do his stunts anymore. So he went into politics, which I think is much bloodier, but that was so yep, that's why good old Arnold went into politics and gave up movie making because he's on warfarin for his prostatic aortic valve. Saprophyticus, none. As far as pigment, it's on the skin, has a bimodal distribution from 5 to 10 to 18 to 24. 5 to 10, why? Little girls experiment. There's no sexual content associated with it. They're just exploring their bodies. And sometimes they'll stick things in their bodies and get these infections. But it's a bimodal distribution because what happens to 18 to 24? They stick other things inside of them, and that's the facts. That is the facts. That's why it has a look at you, Al, right on top of it. That's what I'm talking about. All right. So, woo! No, not going to get that past Al, right? So ultimately, that's why there's this bimodal distribution when it comes to saprophyticus. And UTIs, remember that sometimes they call it honeymoon cystitis or newly active is because basically it's on the skin and ultimately, especially high prevalence in uncircumcised individuals, okay? So that may be a clue on the vignette too. Now, Staph aureus, catalase positive, which means it breaks H2O2, which is what? Hydrogen peroxide. So how do I know? Let's say you have a cut on your skin and it looks a little infected, and you take some of that hydrogen peroxide and pour it on it, and it starts to bubble. Then I know that ultimately those neutrophils are working because that's an oxidative burst. Guys, remember what that is, right? Did Dr. Francis go through oxidative burst with you? All right, good. So oxidative burst, ultimately NADPH, is the first part, taking oxygen, converting it to that free radical, and then ultimately the end result is to make bleach, who's going to kill the organisms. Sokchai, question? Yes. Is it before or after the introduction of lactobacillus? What do you mean? Yeah, it's a part of the normal flora. It's just that it gets out of control anytime you change the pH of the vaginal vault. But it's just a normal part of the flora there. All right, so beta-lactamase breaks through the beta-lactam ring. I drew that out for you so you know it's always the garage door. Coagulase and staphylokinase means it eats through clots. So the most common cause of acute endocarditis, because it eats through the valves, and most common cause of death in burn patients in the first week. They hit this on the boards over and over. If it is the first week, I want you to always pick Staph aureus. If it is after the first week, you're going to always pick Pseudomonas. Pseudomonas. Let me give you another hint for that. Anytime on the boards, folks, you think the answer is Staph aureus, you look down, it's not there, and Staph pyogenes is not there, then I want you to pick Pseudomonas. Pseudomonas always piggybacks Staph. They always go together. You always find both of them together. Now, enzymes, we have lipase, which breaks down fat, and if I have that, I get, as I told you earlier, that paniculitis around the mid-abdomen region, a folliculitis at the follicles, and ultimately mastitis. Again, it's due to the lipase that's breaking down the fat in that area. Now, we have something called elastase, breaking elastin. So let me talk about that for a second. You know, we talk about like alpha-1 antitrypsin deficiency and things like that. The key here is that elastase ultimately, let me see how I can do this. So, breaks down protein. Elastase breaks down protein. Try it again. Breaks down protein. Elastase breaks down protein. So, pancreatic elastase breaks elastin. So remember that elastin, let me think here. So it's elastin plus collagen makes connective tissue. Elastin plus collagen makes connective tissue. So I know that alpha-1 antitrypsin comes from what organ? The liver. Alpha-1 antitrypsin coming from the liver inhibits elastase. Inhibits elastase. Inhibits elastase. So if I have an alpha-1 antitrypsin deficiency, I can chew up the elastin in the lungs, and ultimately, as you know, they will get or cause pulmonary destruction, right? Pulmonary destruction. So this is the key here. I think here. So we have three of them that I want you to know about. Panacenar, otherwise known as panlobular. Panlobular. And then what's that due to? Aging. Aging. Central acinar. Central acinar, or central lobular is what they sometimes call it. Smoking. So every time I go out and I see you guys out there on the deck smoking, here you go. And distal or paraseptal is bullous. So again, now, when we talk about acini, because it says pan, central, or distal, or things like that, folks, if I'm looking at an alveoli, if I'm coming down, it's not one alveoli, it's a bunch of circles, alveoli beds in that area. That's called an acini, acinus to be specific. Yes.
In your notes, not these notes, but previous notes,
Previous notes.
the distal acinar is because of aging, and the pan acinar is alpha-1 antitrypsin.
Previous notes.
Like, it's either in the lung chapter or somewhere.
Okay. And the PB clues? There's some errors in those PB clues, aren't there? I'm going to pick panacinar as aging. I'm going to pick distal as bullous. Okay? Distal as bullous. Yes. Okay, so remember that, as I have there, elastase is one of the things that breaks it down, right? And what's alpha-1 antitrypsin? Alpha-1 antitrypsin inhibits elastase from breaking those proteins down, from breaking the collagen down and elastic.
What pattern would it have?
All of them.
It can be either.
Yeah, because remember, if I'm smoking, I'm going to ultimately affect this area. But all of these, now, I understand what you're saying as far as alpha-1 antitrypsin deficiency. I can get distal if I screw with elastase, because where does elastase come from? Which will answer your question more specifically. Where does it come from? Anybody? No? Elastase. Where does it come from? Neutrophils. Neutrophils. So when you smoke or anything like that, and it starts to release that, I need alpha-1 antitrypsin to help stop that. So any type of pathogen can increase that problem, right? All right. So elastase breaks elastin, bolus, emphysema, pneumatocele could happen. And collagenase, skin and bones breaks peptide bonds, most common cause of osteomyelitis, secondary salmonella. Always remember secondary salmonella. And I put in here for completion the types of collagen that you can find. Type 4, basement membrane. Type 3, endothelial arteries. And type 2, connective tissue. Now, let me explain this slide to you. At the bottom, it is not staph. It is strep. And I have it in parentheses there. You should have it in your notes in parentheses. The reason all three of these are on the same page is because they're all palms and soles. So staph scalded skin syndrome is an exfoliating, which I told you is Nikolsky's sign. Red rash all over the entire body and palms and soles. Toxic shock syndrome has this triad, has high fever, hypotension, shock, rash, palms and soles, and on the boards they always go for retained tampon. Tell you a short story here. I was coming back, I got a break, I was coming back to the wards, and I was coming through the trauma bay, and the whole ER was cleared out. Everybody was outside in the trauma bay. That's kind of weird. And I walked in because I wanted to go in for a second, and got hit with this pungent smell. And I was like, wow, you know, why, now I understand why everybody's outside in the trauma bay. And what happened was this young lady was an immigrant, and it was her first year at the university, and she, friends basically were telling her to use a tampon, and she left it in for 2 weeks. 2 weeks, folks. Folks, it should only be in for a couple hours. 2 weeks. The downside to this is she had to have a total abdominal hysterectomy and bilateral salping oophorectomy. Everything came out. So she lost her right to birth at a very, very young age. So on the boards, they always associate it with tampon use. There is some new questions out where ENTs are getting a little bit overzealous. I just saw a question last month. A student brought it up, and I thought it was a little weird. But ENT decided to shove a tampon up somebody's nose, and they wanted you to pick toxic shock syndrome. Okay? So I don't know. I'd be pretty ticked off at that ENT with a string hanging out of my nose. But again, so the key is that anytime I see the word tampon in a question, you're always going to pick toxic shock syndrome. Okay? All right. Let's see. Erythrodermic toxin is scarlet fever, and that's from strep. That's why I said the sandpaper rash, palms and soles, and strawberry tongue. But palms and soles. Very, very important PP clue. Now, Staph aureus toxins, we have lethacinase causes skin infections in subcutaneous fat. Let's see. Enterotoxin causes food poisoning. How do I know that? This enterotoxin, how do I know that they're going for Staph aureus? Well, if you look, it's fast, 2 to 6 hours. So they use this one, especially if it's like a picnic, a church picnic, and all of a sudden everybody decides to have the potato salad, and before you know it, everybody's blowing out their porthole, and the line outside the church bathroom is longer than can handle it. So again, the key is that it's an enterotoxin causing food poisoning, notorious Staph aureus, and on the boards, like I said, they always go for the picnic scene. Staph epidermidis, catalase positive, white pigment, resides under the skin, and most common cause of shunt infections and central line infections. If I have this, you know that you better be given vancomycin. Why? It is running deep to the skin. I can't play around. I better give vancomycin. But if they're vanc resistant, I give linezolid. Remember, that's the backup for vancomycin, linezolid. Keep the patient in a negative pressure room, which means that it basically draws all that air out of the room. We put a TB patient in the same kind of room. And last but not least, saprophyticus, catalase positive, no pigment, frequently causes UTIs. Remember 5 to 10, they play with themselves, and Al pointed out 18 to 24, they still play with themselves. So again, postcoital, no circumcision, association, and E. coli, most common cause of UTIs. Never forget that. All right. Let's see here for a second. We can go about another 10 minutes. So Streptococcus gram-positive cocci chains. Well, they have these Lancefield groups, group A, B, C, D. Types of hemolysis are more important on the boards, folks. Types of hemolysis. So partial hemolysis, I know they're going to describe a green zone. If it's complete, it's a clear zone. And if there basically is no hemolysis, then I know that basically it's still a red zone. So alpha, beta, and gamma. Now, streptokinase, responsible for beta hemolysis, which is that clear zone. Breaks clots, converts plasminogen to plasma. So you know that if it breaks clots, then ultimately I can use streptokinase as a clot buster. If recent strep infection, that means that they made antibodies to that strep infection, so you cannot give streptokinase to a person on the boards that has any prior history of a strep infection. They're going to try and get you to fall for that. Do not fall for that. So any history of a prior strep infection, do not consider streptokinase. It will not work. So instead we use TPA. Converts plasma to plasminogen to plasma, and again, breaking clots, binds fibrin, and you basically will not clot again. One of the biggest misnomers that I notice, folks, is when you guys think about heparin. Does heparin break a clot? No. It just stops you from making that clot bigger, and then if that happens, then you're hoping for your intrinsic properties to help break up that clot. But sometimes, if the clot's too big or whatever, or there's a vital area that's knocked off, then we got to punch a hole through that clot. And how do we do it? Streptokinase, urokinase, and TPA. The next slide will talk a little more about that. So, urokinase, when would I want you to pick that on the boards? Opens fistulas and grafts. Somebody had a graft transplant, and I know that they're having clots that area, I'm going to consider urokinase. Streptokinase, if basically it's acute MI. They have that thrombotic effect. But if they give you acute MI and a prior history of a strep infection, are you going to ever pick streptokinase? No. TPA, tissue plasmin activator, there's different protocols, but for the boards, it's within 3 hours. Acute MI, acute stroke. There we had this patient on the wards who needed TPA, and the nurse decided for whatever reason she forgot to put it on a pump, and TPA ran straight into this patient. The whole TPA. This person was bleeding out of every orifice. Every orifice. TPA is very, very dangerous. So don't always think, oh, okay, there's a clot, let's pop some TPA in them. It's a very dangerous drug. It's got to be very, very closely monitored. And the antidote, aminocaproic acid for all three. All three. Now, strep pneumococcus, gram-positive diplococci, alpha hemolysis, which means there's a green zone. There are 80 strains, folks, but if we talk about our pneumovax or vaccine, it only covers 23 of the strains. But of the 23 strains, that covers 98% of the strains that cause problems. Cause problems. So who should be on it? Old elderly, right. And on the boards, what is the line of demarcation for elderly? 65 or older. 65 or older. If they're greater than 2 years of age and they have a history of sickle cell disease, why? Because that spleen is gone, they're increased risk for getting capsulated organisms. In organ failure and post-strep glomerulonephritis, meaning skin and throat, can cause this. I have strain 12, and if you remember back to that chart that I gave you with nephritic and nephrotic syndromes, under that, remember M12 was at the bottom? Same thing again. They love that M12. So. Group A, strep pyogenes, beta hemolysis, clear zone. There's 70 strains. And folks, this is one most commonly caused throat infection can lead to rheumatic fever. And Al, what was that valve again that's affected?
First one?
Mitral, followed by? Aortic. Very good. Second most common cause of skin infection. So again, rheumatic fever. Now, group B, strep achalasia, most common cause of neonatal sepsis. Neonatal sepsis. And thanks to Daniel helping us out, neonatal sepsis. And beta hemolysis, clear zone. Clear zone. Group D, strep viridans. Remember mutans sanguinis and salivarius, and they always ask you about the mutans, alpha hemolyx. Green zone, number one cause is subacute bacterial endocarditis, and previous damage to heart valves predisposed to subbacterial endocarditis. Folks, this is why when they turn around and you go to a dentist's office and they ask you, have you ever had a history of rheumatic fever? That means that you would have predisposition to damaged valves. And if they get in there and start digging around on your teeth, there's a chance for mutans to go down to an already damaged valve and cause a problem. So what do? We give them amoxicillin. Now, group D, strep viridans. How would I know they're going for subacute bacterial endocarditis? There's 5 things that they love to put in the vignettes. Septic emboli to the brain is a possibility. You can talk about Roth spots. Folks, that's emboli to the retina itself. Osler nose, emboli to the fingers, very painful on their fingers. Splinter hemorrhages on that nail bed. If we're going back to nail beds again, what did we say earlier? What do we pick if they're talking about pitting on nail beds? What's the cause? Pitting, psoriasis, spooning, iron deficiency. Very good. And Janeway lesions or emboli on the toes. So Enterococcus faecium or facialis, remember that this is a gram-negative, oh my goodness, it's an anaerobe. Gamma hemolysis, red zone, likes immunocompromised patients, and it is nitrite negative. Nitrite negative. How do I treat it? Vanc. Vanc. I don't play around when it comes to things like this. Give them vancomycin. And vancomycin, mechanism of action, is a cell wall inhibitor. So remember, it inhibits phospholipid carriers irreversibly. How do I know that? Treatment for all gram-positives. So toxicity, they talk about red man syndrome. Folks, that's not an allergic response. The person is getting too much of vancomycin. Next step in management, cut back the level of drug that you're giving them. It's just a response to too much of the drug. Intense histamine release is really what turns them red. Just cut them back on the drug. Ototoxic and nephrotoxic for vancomycin. So if it is nephrotoxic, what part of the kidney is it going to affect? What part of the kidney gets affected due to drugs? The tubules and the interstitium. Tubules and interstitium. And vancomycin treatment, I can use it for MRSA, methicillin-resistant Staph aureus. Talking about methicillin. Methicillin, is that a drug we prescribe anymore? No, it's only used in labs, folks. So I'll do a sample on somebody, put on a petri dish methicillin, and see if they're sensitive to it. If they have MRSA, they get vancomycin. If they're methicillin-sensitive Staph aureus, MSSA, methicillin-sensitive Staph aureus, I'm going to give them nafacillin. But because of that, I don't know if it's MRSA or MSSA, so I'm going to start on Vanc. When the cultures come back and they tell me that it's MSSA, I'm going to switch them over to nafacillin. Okay. Switch them to nafacillin. Staph epidermidis, remember bimodal distribution, and Enterococcus. So Vanc again. All right, so meningitis, this is just a review. You have these in your clues just to drive the point home. If I'm talking about meningitis in an infant, 0 to 2 months of age, baby bell, group B strep, E. coli, and listeria. Now, if it's 2 months to 2 years, strep pneumo. But wait a second, look, 21 or greater than 21 years of age is strep pneumo. So you can see the pattern of strep pneumo. But wait a second, who's the ones who are constantly trying to have sex all the time and not thinking about, oh, do I have a condom or not? Well, maybe 10 to 21 years of age, Neisseria meningitidis. If you think 10 is too young for sex, folks, boy, you're in for a rude awakening when you hit the OB wards. Because there are a lot of kids from 9 to 13 years of age having children. It's a child having a child. Right? It's sad. It's sad. But anyway, Neisseria is top of the list there because basically they're fooling around a lot more. Corneobacterium diphtheria. So they're going to talk about a Chinese letter. When I copied this letter, I said, ooh, I don't know, I can't read this, so I'm not sure what it is. I didn't know if it was flipping everybody off or, you know, what the symbol was. And somebody came up to me afterwards and said, it means dragon. I was like, yeah, that's what I'm talking about. A dragon. Woo. So Chinese letters, Corneobacterium diphtheria. Toxin, that ADB ribosylates elongation factor 2. So if I turn around and have that affected translocation of protein synthesis, it's an intracellular pathogen. So what happens is the cell dies, sloughs off, mixes with the mucus, and forms a gray membrane in the back of the pharynx. Folks, if you would ever attempt to scrape this, you will kill this patient. Chances are, if you can't maintain that airway, you could kill this patient. Do not scrape. It will hemorrhage profusely. It's a lot of blood vessels in this area. So if they ever tell you pseudomembrane, grayish in the back of the pharynx, maybe it looks like Chinese letters, again, Corneobacterium diphtheria, folks. And you went through vaccinations with Dr. Francis? All right, I know that's what he's getting ready to go through then. That's the one part he left out. Corneobacterium diphtheria, toxins. Toxins may also cause heart block. And diphtheria, or we have our DPT shots or vaccinations, and it's diphtheria, pertussis, and tetanus is the third component of there. Now, if I give this to a child and all of a sudden they turn around and they get a fever, it's due to the pertussis, folks. It's due to the pertussis. So depending on how high the fever is, if it's greater than 104, I leave the pertussis out. Or if it's less than 104 and they just have a slight fever, the next vaccination, I go to acellular pertussis. And you'll see a little A right next to that P. Acellular pertussis. I'm going to give it at 2 months, 4 months, 6 months. Why? Because they don't have memory at that time. And then ultimately 18 and 5 to 6. I never consider after 5 to 6 because I'm not worried about it after that. Also, they're developing immunity to the vaccinations. Treatment. You always, folks, this is the biggest mistake I see on management questions. If an organism has a toxin, it's not the organism that's causing the problem, it's the toxin. So you must treat the toxin first and then fight the organism. Don't mix that up. So I always give an antitoxin first, followed by an antibiotic. And ADB ribosylators, I know that you know for second messengers. We talk about the GS, the GI. Does it turn on, turn off? Folks, who cares? Who cares? But what they are going to tell you is that GI is affected. The inhibitory is knocked out. The GS, stimulatory, is knocked out. Cyclic AMP. They're going to put all that junk in the vignette. Who cares? And then at the bottom, they're going to ask you, what's the organism that affects this? That is all they're going to ask. So if you know that GS goes with Vibrio cholera and ETEC, and you know that GI goes with Bordetella pertussis, you'll get your answer. It's a straightforward question. And elongation factor, Clostridium diphtheria, diphtheria, I should say, and Pseudomonas. Now, heart blocks, very, very important. Lyme disease, Legionella, typhoid, diphtheria, and Chagas. Chagas disease. If I have Chagas disease, what parts of the body does it love to chew on? January? The ganglia. Right. So therefore, it means I won't release VIP, correct? Isn't that the relaxing hormone? So therefore, what would happen to the lower esophageal sphincter? Remain constricted. Are they going to get GERD? Really? If it's constricted? No, don't apologize. This is okay. This is where I want you to make a mistake, okay?